This research reports results on a project to quantify spontaneous rhythmic bladder contractions throughout the entire filling phase, where prior work focused only on high volume regions. I have no affiliations to disclose. Spontaneous rhythmic contractions are thought to help the bladder maintain tone throughout filling and allow it to prepare for productive voiding contractions at any point throughout the filling phase. These contractions have been identified as elevated in muscle strips from patients with overactive bladder. This study aimed to objectively identify and compare spontaneous rhythmic contractions during the first and second halves of filling in participants with and without overactive bladder. Based on a validated ICIQ OAB survey, participants with and without urgency were prospectively enrolled in a urodynamics study. Particularly question 5A, which asks, do you rush to the toilet to urinate, was used to determine if an individual had urgency. Participants were considered to have no or low OAB symptoms if they answered 0 through 2 on this question. They were considered to have high OAB if they answered this question with a 3 or a 4. Rhythmic contractions with a significant amplitude that was independent of any abdominal pressure activity were identified using a previously developed algorithm. Identified spontaneous rhythmic contractions were grouped based on the percent systometric capacity they occurred. The first half group showed identifiable, significant, independent spontaneous rhythmic contractions at a volume less than 50% capacity. The second half group showed identifiable, significant, and independent spontaneous rhythmic contractions at a volume greater than 50% systometric capacity. Data from 143 consecutive participants with a urodynamics study of sufficient length were analyzed. 98 of these were grouped into the no or low overactive bladder symptom group, while 45 met our criteria and were grouped as having high overactive bladder symptoms. Significant and independent spontaneous rhythmic contraction amplitudes were elevated in those with high overactive bladder symptoms compared to the no or low overactive bladder symptom group. The high overactive bladder group showed an average amplitude of 12.6 centimeters of water, while the no or low OAB group showed an average amplitude of 5.7 centimeters of water. When comparing the corresponding significant and independent spontaneous rhythmic contraction frequencies between the groups, they showed no difference. Only one individual from the high overactive bladder symptom group showed spontaneous rhythmic contractions in only the first half of filling, while the other 17 with both high overactive bladder symptoms and identifiable spontaneous rhythmic contractions showed it either at only high volume or throughout. Spontaneous rhythmic contractions were identified in participants both with and without high overactive bladder symptoms. These results suggest the following. Overactive bladder symptoms may not manifest from all quantifiable contractile activity. Urodynamic studies may cause spontaneous rhythmic contractions in some participants. And contractile activity in only the first half of filling may not be clinically relevant. Additionally, individuals with high overactive bladder symptoms had spontaneous rhythmic contractions throughout filling or in only the second half of filling. Those with high overactive bladder symptoms had spontaneous rhythmic contractions during the second half or throughout filling, as mentioned. Those with spontaneous rhythmic contractions in the first half only did not have high overactive bladder symptoms. This suggests that spontaneous rhythmic contractions during the first half of filling may not be clinically significant or at least might not contribute to high overactive bladder symptoms.